Hello?
Hello?
Hello. Can you hear us?
I can hear you. Can you hear me?
Yes, sir. Can you hear us, Dr. Boles?
Yes, I can. I can
Okay.
hear you.
Yes, we can.
Okay. Will you give me permission to share the screen, or do I already have that?
For the Champagne audience, we are about to start now the CVS.
Should I start the slides?
Yes, sir. Go ahead and start whenever you're ready.
Okay. Are we live now?
We are, yes.
Yes, you are.
Okay. Should I just start? I mean, usually someone introduces me or anything, or has that already been done?
Yeah, we've got taken care of on this end, yeah.
Okay. All right. Sorry about that. Well, let me just get into this. I have many different hats that I wear, and I'll show you in a couple slides. But the main one that I am is I'm a treating physician. This is one of the patients I've been following for many years. Ryan presented with cyclic vomiting. He had episodes that lasted 5 days each of vomiting, headache, and dizziness. And they had an episode exactly every 90 days. Sometimes it would be 89 or 91, and occasionally it was 88 to 92. But it was like clockwork. The family knew exactly when it was going to occur. And every single episode, he ended up being in the hospital for dehydration. He also has ketotic during the episodes. And between the episodes, he has cognitive delay, and chronic fatigue, frequent urination, reflux, constipation, choking episodes, and obstructive sleep apnea. And so I'll get to most patients with cyclic vomiting have similar type problems, other functional like problems. But the main problem with Ryan was he had random explosive aggressive behaviors that he was normally a very nice and kind person, but just suddenly out of the blue, he would attack whoever he was with. And that required him to be, that was going to require institutionalization and medications. And that was the main thing. And he had failed treatment with a lot of the usual things that are tried. Nothing would do anything to the episodes or to the regression. Then genetic testing revealed a variant of interest in the sodium 4A channel. This variant is present in 1% of the population. It encodes for one of the sodium channels on the neuron. There was another one too that's probably not as important. But as soon as I started treating the sodium channel problem with high-dose potassium and propranolol, the problems went away entirely. And on top of that, not only did he go into remission, and he's been in remission for the last 6 years or so, but also his aggressive behaviors have gone away completely. So this I just wanted to show you is an example of when somebody has cyclic vomiting. It's not necessarily the main mutation that causes the disease. Actually, we haven't had a chance yet to do trio sequencing to find out why Ryan has his cognitive delays and other problems. But it was a modifier present in 1% of the population, a normal variant, which predicted why he had cyclic vomiting as part of his disease versus somebody else with the same disorder that wouldn't. And that led to a treatment that went from being hospitalized every 3 months to not having any problems in terms of cyclic vomiting and in terms of his aggression. So this is some of the hats that I wear. Like I said, I'm mostly clinician treating patients. I'm in private practice, molecular and mitochondrial medicine. I do Zoom consults all over the world. If the patient is in a state that I'm licensed in, then I can be on the phone on Zoom with the family. That's California, Arizona, Florida, New Jersey, Pennsylvania, and I'm in the process of getting a Texas license. You can always travel to one of those states, but if you're outside of that area, I can still talk to your doctor anywhere in the world. I can do a consult with your physician to go over to order the right test and to figure out what's going on and to come up with suggestions with your physician. I'm also the chief medical and scientific officer of NeuroNeeds, which is a company that makes products for mitochondrial dysfunction and similar problems. And actually, the treatments that I use in cyclic vomiting are ones I developed myself and I offer through NeuroNeeds. So there's a usual conflict of interest on that. I learned how to read the DNA by being the medical director of two different companies that were doing sequencing, including Cortigen for 5 years, which we actually set up DNA testing to work in things such as cyclic vomiting and autism and many other disorders as well, chronic fatigue syndrome. And that's how I can go through the entire DNA. I don't look at the report. I mean, I look at the entire DNA sequence myself in my patients. Unfortunately, many of these cases get labeled as medical child abuse or neglect or, psychiatric only, and I involved in legal cases. And I also, it's still a researcher. I used to have a laboratory at a university and have funding and everything, but I still write papers based upon my findings in patients. And I'm going to show you some of that data right now. First of all, what is cyclic vomiting syndrome? If on the other side of the Atlantic in Europe it's called cyclical vomiting syndrome, but in the United States it's just without the AL, cyclic vomiting. It's the same thing. This is like almost all diagnoses. This is defined based upon signs and symptoms. It's not defined on what the problem is. So if you meet these criteria, you have CVS, but it doesn't say exactly what the problem is. It's really episodes of nausea and vomiting. That's it. The episodes are significant, meaning that most people don't have nausea and vomiting between episodes, but a lot of the adults do have some degree of nausea, maybe even a little vomiting between episodes. But the episodes are much worse. So it'd be like a 9 out of 10 of nausea during the episodes and maybe a 3 or 4 between episodes. So their episodes are distinct and significant. Also, the episodes are stereotypical. I'm going to show you some slides that show you all different types of episodes, ones that last 6 hours, ones that last 2 weeks, ones without vomiting but have dizziness, ones that all different types of and problems, some with headaches, some without. But in a given patient, all the episodes are similar. So that's what we call stereotypical. And the episodes are multiple. You just don't have 1 or 2, but they just keep coming. So if you have episodes of nausea and vomiting that are significant, distinct, they're stereotypical, similar to each other, but not identical, and multiple, that's cyclic vomiting syndrome. And there's many different causes of that. This is a paper that was published in 2023, so just over a year ago. And what we did is looked at 80 patients with cyclic vomiting syndrome and looked at the sequence of all of the genes. Whole exome is to sequence all 23,000 genes, and whole genome is the same, but also looking at the DNA between the genes. A few years ago, we used to use whole exome. Now I do whole genome on everything. And here's another paper. This one's hard to find, but I can help you get it. This is based on the same data, but it's clinically. The other one is really what are the genes and what is cyclic vomiting syndrome. This one is, okay, for the clinician, how does that information make a difference? How can you treat it? And it goes over case reports. Some of those case reports I'm going to show you now. This is just the patients that were involved. They all have something different about them. Triggers are different. prodromes, things that happen before the nausea. Some have it, most don't. Manifestations during episodes, by definition, they all have nausea and vomiting, but many of them will have other things, particularly fatigue and lethargy in 62, pain in 48. How frequent the episodes are and how long the episodes are. Each person differs on these, but of course, each person has a stereotypical pattern, at least over months or whatever. In over years, it can and does drift. And here's the comorbidities, the things that you have with it. One thing is that cyclic vomiting syndrome almost never occurs alone. It occurs with other problems. And you can see pain, other GI problems between episodes, problems with the autonomic nervous system, allergy, immunology, things, sleep. Those are all extremely common. You can see anxiety, 51 out of 80. And then there's more things here. But the point is that almost everybody has other problems in addition to these episodes. And this has caused me and Dr. Gardner years ago to put all these on this poor, sick elephant, that cyclic vomiting syndrome is one manifestation of functional disease, that most of the patients will have others. Now, almost nobody has everything on the elephant, and there's like 30 other conditions that are also paroxysmal or that happen from time to time that are neurological and could be considered functional disorders to put on the elephant again. But I thought the elephant was severe enough as it is, and more problems make it hard to read it. But these are some of the more common ones that are seen that happen together. If you have any one of these conditions, you're more likely to have another one. And if you have any one of these conditions, your first-degree relatives, your parents, your siblings, and your children are more likely to have that or any other of these relatives. So our common genetic factors that predispose towards all of these. Doesn't cause anything, the genetics, but it predisposes. And that's actually what I'm getting to in my research, is what are the genetic factors that predispose towards all the problems on the elephant. And then chronic fatigue syndrome is also one of them. That's why the elephant's lying down. So the study that was published a year and a half ago was to look at 80 unrelated participants and to sequence all of the genes by exome at least, or genome, which is even more. And to try to figure out what the genetic components are that predispose towards cyclic vomiting syndrome, and to use that to try to understand what can predispose towards everything else on the elephant. I don't have a lot of time here, and I want to spend most of the time on diagnosis and treatment. So I don't have a lot of time on the science, but it came out that every single gene, and there was about 28 or so genes that were involve ion channels or energy metabolism. So an ion is a salt. Cations are positively charged salts. Cations are sodium, calcium, and potassium, but there are others like zinc and magnesium. So a cation channel is like a sodium channel or a calcium channel or a potassium channel, as you can see on here, is that sodium goes into the cell, calcium goes into the cell, while potassium goes out of the cell. That's because we have pumps. We have pumps that use ATP or energy to pump sodium into the cell. Generally, they pump the potassium out of the cell, and it's very complex versus the calcium, but it mostly goes out of the cell as well. And this is an exchange pump, but there's many, many other pumps. Most of the pumps pump sodium out. This one exchanges it with calcium. So you pump the sodium out, which pumps the potassium in, and then you pump the sodium back in to pump the calcium out. It's very complex. But the thing is that if any of these channels are leaking, let's say a calcium channel is leaking and calcium gets into the cell more than it should be, that's going to affect all the other cations, because the sodium leaks in, you're going to have to pump it out. And that's going to affect all the other channels, and that's going to take a lot of energy from the system to try to pump it all back. Now, energy metabolism happens in the mitochondria, and that is making the energy that you need. Energy is life. Without everything that the cell does, almost everything in every cell requires energy. So if the energy metabolism is not working very well, there's going to be problems, and almost anything could be a problem. It's a risk factor for almost everything. So these are the two components that I want to talk about. These are the two causes of cyclic vomiting syndrome. So this is a complex slide. This is the actual data. These are, on the far left, are the gene names. And then there's how many points they had based upon the study. In other words, how many mutations in each one and the type of mutations and everything. I don't want to get into the detail, but in this one here that says composite, the red ones are very highly related to cyclic vomiting syndrome, and the orange ones are related, meaning that the red ones are certainly cyclic vomiting genes, and the orange ones are likely cyclic vomiting genes. You'll notice that both CHAMP1 and POGS are orange. That doesn't mean that I don't think they're cyclic vomiting genes. That just means that they're rare causes of cyclic vomiting. So in the study, we didn't have a lot of examples. And so it got orange. But I do believe that definitely that they are related. What I wanted to show you most of all is the arrows in the middle column here. Every single one of these genes, and there's a lot of them here, is related to cation transport or energy metabolism, or both. So the ones that are solid blue, those are actual cation transporters. Those actually move cations. The ones in light blue, like CHAMP, are indirectly involved in cation. The gene does not involve cation transport, but CHAMP1 defects do affect ion transport. The ones that are in red are genes involved in energy metabolism. They're actually genes that are directly involved in energy metabolism, while the ones in pink are indirectly involved in energy metabolism. As you can see, that another syndromic cause of cyclic vomiting syndrome caused by the PPM1D gene, and that causes a similar syndrome, and I'll show you a patient later. That gene does not actually make energy, but it is, if you have a mutation in that gene, it affects the energy of the cell, so it's indirect. So you can see that even so, every single one here is involved. I mean, the POGS here and the CHAMP are indirectly involved in ion transport, and the PPM1D is indirectly involved in energy metabolism. So the syndromic varieties tend to be indirect, but most of the cases of cyclic vomiting that are not syndromic tend to have direct transports in energy metabolism or cation transporters. This just shows that energy metabolism and cation transport are not independent of each other by any means. If you have a leak in one of the ion cells, you're going to run out of energy, because the leak is a leak in cations. Cations are positively charged. When a cell is positively charged, it does its thing. It goes on. A nerve will send an impulse, a muscle will twitch, a endocrine cell will release hormone, a mast cell in the immune system will release mediators, et cetera, et cetera. That tells the cell to do it. What are you supposed to do? This is your job, do it. If there's a leak of positive charge, it makes the cell activate, and that causes symptoms. But activated cells need more energy, and it causes a lot of energy to pump it all back out. So if you have a leak of cations, you get an energy metabolism. On the other hand, these channels are opening all the time to send signals or for the muscle to contract. You need energy to be able to pump it back out. If you have a primary mitochondrial disorder, a primary disorder of the mitochondrial energy metabolism, you're not going to be able to pump out the ions as fast as the cell is signaling. And so you will get a cation problem. They will build up. You can't pump them out fast enough. And so if you have an energy metabolism problem, you get abnormal cations. If you have a cation problem, you have abnormal energy. And it goes in a cycle. And that's really what the episode is a vicious cycle. It goes round and round. And so either one will cause the other. And the treatment for either one is both. To intervene here and to intervene here is how I treat it. And that you can see that some of them, like here, CHAMP1 and POGS, indirectly come into it to this point, and then it goes into the cycle. This is a very, very complex slide, but All of these genes are on the slide, and the point is that they all are in the vagus, and this is the vagus nerve that goes from the gut, and this is the brain stem here. So all of these genes work in the vagus, or where the cell of the vagus synapses with. So I call this the vagus unit, is the cell that it synapses in the gut, the vagus nerve itself, the glial cells which help it, and the NTS, which is a part of the brainstem that the vagus synapses on, the vagus nerves from the gut. And this is the anatomical location of CVS in multiple, in many different studies. And this is what I can see from my study. This is where the problem is. It's not in the gut. It's in the nerves. It is not in the upper part of the brain. It's not psychiatric. It's in the nerves that send signals from the gut to the brainstem and in the brainstem itself. And this is an issue because many of the drugs that we use don't really cross the blood-brain barrier. You need to get all the drugs into the brain really to fix it, because this is often where the problem is. So I've gone over a lot of these genes. I'm highlighted in green here are the most common genes that are affected in cyclic vomiting syndrome. You can see that Ryan had sodium 4A. I'm going to show you some other ones. And then the syndromic ones. What I mean by syndromic has neurodevelopmental problems such as intellectual disability, seizures, autism, etc., and or birth defects with it. So when we call syndromic, we're usually saying that it involves the brain in a more generalized pattern. And or it causes birth defects. It's with syndrome just means things that go together. So the syndromic causes of cyclic vomiting syndrome, and here's 5 of them. There probably are others that we haven't found yet. You can see that the POGS and CHAMP are on here. They indirectly affect ion transport or energy metabolism, and I believe that's how they cause cyclic vomiting in some people, but not in everybody, because it's probably these genes here that put you over the edge. A syndromic gene gives you some of the risk, but to really get cyclic vomiting, I think you need to have one of the other mutations. Here is Molly. She has some JDVS, and that is due to the PPM1D gene. It's one of the syndromic causes of cyclic vomiting. And they had last year, they had a conference somewhere on the East Coast. I'm in California, so they're somewhere on the East Coast. And that's something that you might want to consider having some relationship with them as well. So Molly presented at 1.5 years of cyclic vomiting syndrome. She has a mild intellectual disability. She lives independently, but she needs some help in some things. And the point that I want to mention with her is that even at age 41, her episodes came back. They increased to 1 or 2 per week. She also had some other issues. At that point, at age 41, we started her on the mitochondrial cocktail, spectrum needs, which is 30 active ingredients, and some additional type of CoQ in the ubiquiform oil and fish oil, an omega-free source, and her episodes dramatically improved. So it's never too late to help with cyclic vomiting. So even in a 41-year-old, we're able to take it from having very frequent episodes to having quite rare episodes, and so Molly's doing much better. I'm not going to spend a lot of time on this one. Okay. I do have 2 cases with POGS, but one of them I don't have much follow-up on. Kate is one that is published in one of those papers as a case report. She presented at age 3 with cyclic vomiting. The episodes caused over 40 hospitalizations between the ages of 3 and 16. And then it went away, and in college, it went to ocular migraine. And she has the many other comorbidities, which I've showed you before, that are very common, that Molly has, that Kate has, that Ryan has, that almost all of my patients have. Different combinations of problems on the elephant. Pain, urinary frequency are pretty common. Hypermobility is not that uncommon either. Hearing loss in a minority. but also parasomnia. So that's weird things that happen during sleep. That's pretty common. She also has high functioning autism, but she's very high functioning. She has a master's degree and she works for Special Olympics. The White Sutton disease is a really perfect, and of course she has a de novo variant in POGS, and that's the one right here. De novo meaning it's not present in either parent. This fits, you can read this, but here it fits her completely. I mean, she has all of the problems that you see in POGS disease, and as well as her face fits the problem really completely. So she definitely has the disease, but she's a more high functioning one. This is what I want to emphasize, is that her family history is positive for all of these problems: migraine, fatigue, GI problems, muscle weakness. But she has a de novo variant. It's not the POGS that's causing that. It's the other things. When I did the sequencing at her in her 30s, I found that she has a variant in TRAP1, and that's one of the genes that was highlighted in a slide earlier. This is one of the main autism genes. I'm not sorry, it is autism too, but this is a main gene involved in cyclic vomiting syndrome. And she has POL gamma, which is another gene that's involved in cyclic vomiting syndrome. Both of these genes are primary mitochondrial genes. This protects mitochondrial, TRAP1 protects mitochondrial proteins in high oxidative situations. And POGS encodes for the enzyme that replicates and proofreads DNA. So POGS by itself is probably not going to cause cyclic vomiting. It's these genes that are pushing her to cyclic vomiting syndrome. And this is why her family members have many of the things on the elephant. So again, it's very important to find the modifying genes. Yes, you have a diagnosis. That's why you're at this meeting. Somebody has done DNA sequencing, but you really, if you have cyclic vomiting syndrome, we need to find the other parts of the genes. So after all, POGS or CHAMP1 is just one variant out of 3 billion. The rest of it does matter a lot. So here's the slide before that I showed you. And again, that CHAMP1 and POGS are involved indirectly in energy metabolism. There's also, I didn't mention, there's 2 of these genes that are involved in energy metabolism and autoinflammation. And that's a rare thing as well. Some of them are involved in that. That doesn't cause it by itself, but some of the patients do have that. And that's another treatable one. I don't have a lot of time here, but this is for the researchers in the group. If you can get my slides, this is the connection that I've been able to make on CHAMP1 and on POGS. As to what the genes do and how that they're involved in pathways that are common in cyclic vomiting syndrome. It's cellular hyperexcitability, which is the problem. And CHAMP1 downregulates many genes, including the solute ligand carrier 6A1, which is a GABA transporter, and other ion. And the GABA transporter is a chloride channel. And there are other ion channel genes that also CHAMP1 regulates. It means it turns them up or turns it down. And I think this is how it is contributing to cyclic vomiting syndrome. POGS is a little bit harder to put in there, but there is evidence that there is neuronal excitation to inhibitory balance if you have POGS insufficiency. And so I think that this increases the neuronal excitation to inhibition balance, and it's the other ones that put you over the edge. So these just kind of give you an initial shove, and it's the other mutations that go over the edge. Okay, so having said what cyclic vomiting syndrome is and what causes it, what can you do about it? These are the common treatments that are used around the world for cyclic vomiting syndrome, and this is based upon a paper that's now quite old, almost 20 years old. That was I'm one of the co-authors on it, and this is for pediatrics. And there's a much more recent paper by another group that overlaps a lot for adults. This is a large part of my solution. All of these foods have in common is they have a lot of potassium in it. When you give a lot of potassium, it gets into the cell in a very complex mechanism. It chases out the calcium, particularly, but also the sodium. That's why I was showing you all of that about the ion channels, because that's really what I use. The fact that if you give too much of one ion, or if you have a deficiency of an ion, or if you have a mutation in an ion channel, it's going to affect all of them because of all of the carriers, all of the SIM ports. It moves one in one direction and the other in the other direction. When you add a lot of potassium to the diet, it does chase the calcium out, and that is often very helpful. Also, magnesium and calcium look very similar. So if you get a lot of magnesium, that also helps reduce the calcium. So I will give a high potassium diet to see if that works. And sometimes that's all that's needed. Ryan is on a high potassium diet. He does not need potassium tablets. A very, very good way to get a high potassium diet is pomegranate juice, also coconut water, but there's many other ways to do it. But pomegranate juice is a good way to do it without a prescription. A lot of my patients are on prescription potassium. Some of them are on extremely high doses. I start low, go slow, get some results. I try to put the potassium level between 4.5 and 5.3. In other words, on the higher side of the normal range. Ones on the lower side of the normal range, even though they're normal, can precipitate episodes. And it's hard to explain to an emergency room physician that it's in the normal range, but you have to bring it higher, but that's what it needs to be. So here are some of the treatments that I use. The potassium chloride is used for many of the channels. I'm using it more and more for RYR2, and I think that it works, but I'm not sure. RYR2 channels, I use propranolol. Acetazolamide or Diamox I use for some of the channels, but only if the potassium level is on the higher side. Otherwise, you chase the potassium into the kidneys, and then the potassium level goes down, you have more trouble. The sodium channel ones that are highly related to cyclic vomiting syndrome don't really work as well with ions. I have to use drugs like gabapentin or duloxetine are my favorites. Mitochondrial cocktail is important for all of them, because it is, you need to have the energy to pump out the ions. And also you need more energy because there's cellular hyperexcitability. Cannabis products are sometimes helpful, particularly in some of the more rare sodium channels that are related. And any of the sodium channel ones, sometimes they respond to the anticonvulsant genes. By the way, the sodium channels are also a very common cause of epilepsy, but they can cause cyclic vomiting. The absence of epilepsy and an anticonvulsant will work on the same channel. Mitochondria is shown in all of these papers to be related to cyclic vomiting. Those are all the public papers that have shown that. This is not just this one study, but abnormal mitochondrial production has been shown in multiple studies to be related. Cyclic vomiting. These are actually all, I published all of these, but there are some others. These are the components of the mitochondrial cocktail, but there's many others on there. The mitochondrial cocktail is not one, two, or three things, but it is many things that help the mitochondria and that detoxify the mitochondria of their antioxidants, because if the mitochondria is not working very well, it becomes very pro-oxidant, and that causes damage. And this is just to show you that that energy is made in an assembly line. This is what the electron transport chain looks like in real. This is a false color, but this is an actual picture. It's an assembly line. If you give this guy here his vitamins, he's not going to make cars faster. He's going to make chaos. So a lot of people will do is they'll give like 10,000 times the normal amount of one vitamin to see what happens. That just causes chaos. What I do is I give moderate amounts, moderate to high amounts of all of the vitamins that help the entire chain. And then that's how I make more energy. And it works a lot better and has far less side effects. So people will say, oh, you give one thing, you get a lot of side effects. Well, you give a lot of them, you have less side effects, which is sort of counterintuitive, but it's reality. And this is just to show you that as apex predators. I don't know if this is some of the things that I have made for cyclic vomiting syndrome, and I use it all the time. Over 95% of my patients are in remission. They don't have vomiting episodes anymore. It takes a while to get there sometimes. This is a mitochondrial cocktail with 40 different ingredients in capsule form. This is almost the same thing in powder form. This is at neuroneeds.com. And then I add the coenzyme Q10 to that because it's in an oil form, and most CoQs you can't put it in the powders. Most CoQs over the counter are worthless. This is a very highly available. And then the omega-3s. Everyone should be on omega-3s. They're very important. We don't get them in our factory-made diets. The krill oil has omega-3s that go across the blood-brain barrier. Fish oil does not. But fish oil is great for the rest of the body. So a krill plus fish oil brand is what I use in my patients. So I do recommend a mitochondrial cocktail. Spectrum needs and energy needs are the ones that I have designed. And I own part of the company, so I have a conflict of interest. ANRC is a competitor, and there's a couple other competitors out there. So whatever brand you use, I would recommend to use a combination mitochondrial cocktail to add the ubiquinol form of coenzyme Q10 and an omega-3 source, particularly an omega-3 source that includes some krill oil. I do recommend to do testing, whole genome sequencing to find the other genes that are involved. So certainly you can use the mitochondrial cocktail, you can use potassium, you can use magnesium. If sequencing is not an option, those are things that you can try. But if you find the exact mutation, you're much more likely to be able to the first time to know what to use and not just throwing things and seeing what works. And never give up. CVS is treatable. As I said, over 95% of my patients are in remission. They may have an episode once a year or every other year or something like that if something happens like COVID or whatever, or appendicitis or a broken leg. But CVS is treatable. It's difficult to treat. It takes sometimes multiple different changes, DNA testing, and sometimes it can take a couple drug trials. But almost everyone can go into remission now that we understand the cause much more. And this is the take-home message. People with a de novo mutation, like in POGS or in CHAMP1, they may or may not develop cyclic vomiting syndrome. It depends on inherited variants, and those variants may be common variants, like in 1% of the population. They won't show up on a normal DNA test. The variants are generally in cation. The risk variants are generally in cation and energy metabolism. Dietary supplementation can target these pathways, and occasionally medication, but I'd say 80% dietary supplementation can do, 20% medication. Whole genome sequencing could identify these risk variants, allowing for individual therapy, and CVS is highly treatable in expert hands. You shouldn't have to suffer. The CVSA organization in the United States, there's another one that's CVSA UK in the United Kingdom. And then this is my contact information. If you're interested in NeuroNeeds products, that's how you get to NeuroNeeds, just neuroneeds.com. And if you're interested in my looking at the DNA to figure out what's wrong, oh, that's the wrong one, email. Sorry. Let me get to that one. Oh, shoot. It's been changed. Sorry. It's right here. This is the email that will go to Liz, who's my coordinator. You can also email me and I'll send it to Liz if you want to take a screenshot if you're interested. I'll just leave it here. Are we going to have questions or is it over?
We've got a few questions on the chat one side, if you're happy to answer them.
Certainly.
Yep. The first one I've got is someone said, it seems that Laroxa works managing CVS. What do you think? And is there any are there any issues with giving it to someone under 6 years of age?
What was the drug name or?
Laroxil?
I don't even know what that is. I'm sorry. There may be another name in the United States.
No, it may be something, it may be a European name, but it's something we can follow up on.
Yeah, I'm not familiar with that one. If somebody could just check to say what the generic is, I might know it.
Yeah, that's fine. We can follow up with that one. And the other is, do you have an explanation for why the cold seems to make cyclical vomiting worse in the sun or one of our champs? Can you help? Yeah, do you have an idea of why that is the case?
Well, it's one of the modifying genes, most likely. The modifying genes are inherited and they inherit down. And so when the patient has a modifying gene, it came from one of the parents. Often there's more than one modifying gene, and they often come from different parents. And siblings may have, one, two, or zero of those, and children will have the same. So it's really how the modifying genes segregate. And in many of the times that I've looked at siblings, they'll have a modifying gene, the same one that that the patient had, the person with the more severe disease, but they may have their own modifiers that the patient did not get. So it's complicated. It's polygenic. I'm trying to make it somewhat understandable in this, but each of those patients I showed you has mutations in like 3 different genes. And I think that it's really none of them by themselves will do it. It's a combination.
Yeah. And just clarification on that drug, is amitriptyline is the equivalent.
Oh, okay. Yes, I know that one very well.
Yeah.
Amitriptyline does 1,000 different things. When I looked into it to try to figure out what it is, it works on so many things it's difficult to do. But one of the things that amitriptyline will do, it's in some papers from like the 1950s or something, is that it will uncouple oxidation and phosphorylation. So in other words, you burn fuel, but you don't make ATP. So you think that would be really bad because you're making less energy. But I don't think the problem is not having enough energy in these patients. I think the problem is that in making too much energy, you make a lot of free radicals, and that damages the cell, and that damage is causing the symptoms. Amitriptyline uncouples it so that you're making less AT, but you're making a lot less free radicals that damage the cell. So that may or may not be part of what it is. I use amitriptyline in the few cases that I don't find anything at all on the genetics, and that's like 10%, because it's probably the most effective drug in cyclic vomiting. And I also used it when in the mutations that I didn't go into this, but there are also people with cyclic vomiting that have mutations in genes that are involved in peripheral nerve cell in many different ways, like in the myelin sheath. These are generally ones that cause neuropathies, like Charcot-Marie tooth. Amitriptyline is the best treatment for people that have mutations in those genes who did not respond to the usual treatments that I do. So in the past, like 20 years ago, I used amitriptyline in almost everyone because it was the most effective drug. Now I pretty much only use it in cases that don't get better, particularly when they have a mutation in a gene that predicts amitriptyline use.
And I think we've got one more question this side, so I'll just pass you over.
Hi, hello. I was just wondering what your thoughts on ciprofloxacin were. That's a medication that we currently take, ciprofloxacin.
How old is your child?
He is going to be 3 next month, or in
Okay.
December.
Ciprofloxacin works on that other pathway, the one that's involved in the inflammation. And sometimes it works. And in my opinion, most of the time it doesn't. Ciprofloxacin almost never works after kindergarten. When you get to about age 6, it almost never works. But in some of the little kids, it does work, and it works on that other pathway. If you thought my presentation was complex enough, it's a more complex even yet. These questions are bringing out that said, yeah, there are other things. But usually, in fact, I've never seen anybody that has an inflammatory gene defect that didn't also have an ion channel or a mitochondrial. So if somebody is on ciprofloxacin and it's working great, I wouldn't change it. But if it's not working so well, and particularly when the kid starts getting towards 5 or 6 years of age, you may want to do DNA testing to find out what other options are available, because the child will most likely start breaking through.
Okay, that sounds great. Thank you.
Over to you, Josh. That's all our questions, I believe.
Can you hear me, Dr. Boles?
Yes.
Do we have any questions for our audience? Yep.
Where are the audiences?
Hi, my daughter is 25 years old, and ever since she was young, she did have days where she can like throw up from the time she wakes up. She'll say she doesn't feel good and she's a little sweaty, and she'll puke almost all day. And then by 5 o'clock that night, she feels fine and she can eat a meal, and sometimes it happens once a week. Sometimes it can happen not for a little while. So we always had no rhyme or reason to it, and none of us will get sick. So we always just kind of say it's what's happening to her. So is this fitting into the cyclical vomiting is my first question. And then my second question, some of the things that you posted, the cocktails and the vitamins, do any of them have a lot of interactions with psych meds, or are those types of things you're free to give to try to help with cyclical vomiting?
All right, those are good questions. First of all, absolutely, yes, that's cyclic vomiting with shorter episodes. But great that they're shorter episodes, but they're still, it's horrible to go through that. And I would recommend to pursue that with treatment, diagnosis and treatment. And the second one regarding medications, I would say the vast majority of my patients are on medications for some reason or another. They have other comorbidities. And about half of them have comorbidities in the neuropsychiatric or neurodevelopmental area. And they're on, you would consider psych meds. And I do not see any problems with any of the psych meds and any of the products that I've discussed. I've never seen any problems with it. I mean, having said that, I can't anticipate every patient, every genetics, every medication, every supplement your child is on. So consult your physician on this, but I have not seen any interactions or any problems. In fact, the vast majority of my patients are on the medications of some kind.
She said, okay, thank you. Dr. Boles, I have a question for you myself. Have you seen a pretty typical evolution of cyclic vomiting as children age? Our son was very severely affected early on, and still has an episode from time to time where we have to use rescue meds to try to stop what our doctors have called stomach migraines, which again, I'm not really sure what that means, but they're saying that that's what's causing it, is some sort of a stomach pain. But it's not as common as it used to be. Is that typical?
Well, there's a few things in there. First of all, stomach or abdominal migraine is not an inaccurate word. That's really the same as cyclic vomiting, in my opinion. And many of the patients that have abdominal migraine with stereotypical pain in a particular part of the abdomen that happens in episodes, they will develop cyclic vomiting, or vice versa, or somebody else in the family will have it. And I have a lot of abdominal migraine patients, and the genetics are the same as cyclic vomiting. So in my opinion, if cyclic vomiting, if nausea is the worst, abdominal migraine, if pain is the worst. And there's a lot of patients that say, well, the pain and the migraine are the same and they're just as bad. And then you can just throw it. I mean, it's arbitrary between the two. It's the same condition. The other one is, I mentioned like that one patient that went from vomiting episodes and then for 3 years had nothing and then went to ocular migraine. Usually there's not that honeymoon period, that it usually goes from one to the other rather quickly, maybe in a few months or maybe a year, but not 3 years. But it does evolve. People's episodes can go from being with vomiting to mostly dizziness, or vomiting to only nausea, or migraine, or headache, or other things. Sometimes the episodes look seizure-like and that they lose consciousness, or they act psychotic and don't know who they are, or catatonic and they don't move or anything, and that they're just very atypical migraines. It almost always develops over time. As the child develops, so from an infant to an adult, there's huge changes, and the episodes will not be the same. But at each age, they're stereotypical.
Okay, thank you very much. I think that's all the questions we have. Do you guys have any questions with Champ 1?
No, that's all from us. Thank you very much.
Okay, thank you very much, Dr. Boles. We really appreciate you.
You're welcome.